As you can see, the topic of my talk is updates in glomerular disease. Now, this topic, each single learning objective from this topic could be its own hour-long discussion, and I promise you my talk is not going to be 4 hours. Why did I choose to pick this topic? Well, when I was a house officer, I remember that there was a lot of renal nihilism, thinking that there's not much that we can do for these patients outside of diuretics and ACEs and ARBs. So why even consult renal to get a renal biopsy? Let's just wait until they're on dialysis. And hopefully this talk will prove to you that we are moving away from that. I have no conflicts of interest to disclose. Before I get into my learning objectives, why do I like glomerular disease? Well, outside of the fact that zebras are fun, I really think it requires you to use all the different types of parts of our brain that drove us into medicine. You have to have a good understanding of physiology and pathophysiology. You have to have a high index of suspicion and be aware of some of the stranger things in medicine, but also in taking care of patients with glomerular disease, it requires you to get a renal biopsy. So you can stare that disease in its face, and based on what you are seeing, based on the morphological characteristics, you can try to put together a diagnosis. And then it also has some of the drama, the wins and fails of oncology with inducing remission and having those victories, but also dealing with the relapses. So moving forward, for my learning objectives today, I wanted to start by just reorienting ourselves to some basic glomerular architecture so we know what the heck are we talking about. Hopefully that will allow us to have a better idea of how these diseases are occurring and how some of our treatments actually are supposed to work. Then using that framework, I want us to kind of look at glomerular disease with some overarching common immunologic insults. I'm sure as anyone has recognized, once we scratch that thin veneer of pathophysiology, any complicated disease today or not so complicated disease has a strong component of immunology. And then the specifics I want to talk about are new antigens in membranous nephropathy, APOL1 mediated kidney disease, and then some new therapeutics of SGLT2 inhibitors, IgA nephropathy, lupus nephritis, and ANCA vasculitis. So to start off, I want to just, again, go over what are we talking about here. So this is a classic cartoon that many of us have probably sweat over in medical school, looking at the glomerulus, which has 3 main cell types. We have an afferent arteriole that comes in and forms a capillary network with a fenestrated endothelium that is anchored to a glomerular basement membrane with epithelial cells or podocytes on top of it, with many interdigitating foot processes that form that filtration barrier, that slit diaphragm. Based on which cell compartment is injured, gives us that spectrum of nephrotic to nephritic syndrome, and various diseases affect different compartments. In glomerular disease, a lot of our diseases are named on pathological diagnoses. What does it look like under the microscope? So for instance, FSGS is a podocytopathy. It's a disease that destroys podocytes. But as you can imagine, that can happen from a lot of different ways. And it's quite an umbrella term. Now, as we understand more about the pathophysiology, we're moving towards a little bit more specific diagnoses. That cartoon isn't great. It took me, not until I was a renal fellow did I ever really wrap my head around it. Again, this is it zoomed in, capillary with a fenestrated endothelium, glomerular basement membrane, and that interdigitating podocyte. When I saw this cartoon in Robbins, which is the same cartoon just rotated a little bit into 3-dimension, we can kind of get a better idea that the mesangial cells serve as scaffolding. And then again, the podocytes interacting with other capillaries, but it's still not great. And hopefully this electron micrograph will show you that each podocyte interfaces with many different parts of the capillary. And again, they have these long foot processes that interface here, causing your slit diaphragm and your filtration barrier. And that proper functioning of podocytes is integral into having your kidney work properly. It has this slit diaphragm, which, as we can see here, requires a lot of specialized cytoskeletal proteins such as actin, integrins to anchor the podocyte to the GBM, and also proteins to actually create that slit diaphragm. And here's just another zoomed in view to hopefully hit you over the head with enough time so we can move from that initial cartoon that is a little confusing to something that may make a little bit more sense. Why do we care about this? Well, podocytes are terminally differentiated cells. Once they are harmed, if they fall off and die, you don't get any back. What's unique to podocytes is they are the only cell in our body who are pushed away from their basement membrane, not towards it by the blood flow. So based on what we showed in this last slide, you could imagine there's a lot of complex processes that keep this cytoarchitecture intact. Once there is some insult to the podocyte, it's very easy for it to get pushed off of the glomerulus and into the urinary space. And in fact, we can culture viable podocytes from the urine of patients with nephrotic syndrome. Why is that important? Well, initially, you can try to hypertrophy your podocytes and have them lay down their foot processes in something you may remember called foot process effacement. And that can cause them to not filter as well and the beginnings of proteinuria. But if we hit a critical loss of podocytes, we can no longer cover that denuded glomerular basement membrane, and that leads to glomerular sclerosis and scarring, or FSGS in our terminology. There are many ways to hurt the glomerulus, and I don't want to spend much time on this slide because, again, each one of these could be its own talk, but depending on where the lesion is, denotes the type of glomerular disease. In primary membranous nephropathy, you have immune complexes under the podocytes. In diabetic glomerular disease, it is a thickening of that GBM. Amyloidosis is the deposition of amyloid fibrils within the mesangial compartment, and everything in between. When we think about many of our glomerular diseases, again, there is some involvement of the immune system, and a lot of glomerular diseases involve immune complex deposition. That can happen in a few ways. We can have circulating antibody-antigen immune complexes that then get deposited in the glomerulus just due to the fact that the glomerulus is highly vascular and the kidney gets about 25% of the cardiac output. You know, the heart's job is to pump blood to the kidneys. Another way that can happen is if you have circulating antigen, such as an infection-related GN, that antigen can get stuck within the glomerulus, and that can recruit antibodies there. And also, you can have an autoantibody that recognizes an antigen within the kidney, either on the GBM, as in anti-GBM disease or Goodpasture syndrome, or in primary membranous nephropathy, which we'll talk about a little bit later. So, like I said, once we scratch the thin veneer of the pathophysiology that we're all familiar with, the immune system is integrally involved in all of these diseases. And as we start to look at them more, to me, there are some common pathways. So again, I don't want our eyes to blur or cross too much looking at this, but in membranous nephropathy, what happens? There are autoreactive plasmablasts and plasma cells that make an autoantigen that recognizes an autoantibody that recognizes a glomerular antigen. You have deposition of immune complexes, activation of complement, recruitment of the immune system, leading to interstitial nephritis and glomerular sclerosis. In IgA nephropathy, you have plasma cells within Peyer's patches that make a galactose-deficient IgA. That epitope is recognized by antibodies that form a circulating immune complex that gets deposited within the glomerulus, activating complement and recruiting the immune system, leading to nephritis and glomerular sclerosis. Lupus nephritis, you have, due to derangements in autophagy, you have the exposure of intracellular nuclear antigens, leading to activation of the immune system with plasma cells making autoantibodies that create circulating immune complexes that get deposited within the kidney. And just because I am sick of hearing myself say this over and over again, something similar happens in ANCA vasculitis as well. Although this disease is slightly different, I'll talk about that in the future. So again, because there are these common pathways, we are starting to use similar therapies that target the immune system for all of our glomerular diseases. So glomerular disease also is a spectrum. You can range from asymptomatic microscopic hematuria, or you can have rapidly progressive glomerular nephritis. Also, some of the same glomerular diseases, IgA being a very good example, can fall on this spectrum from microscopic hematuria all the way to crescentic glomerular nephritis. When do we start to think of glomerular disease? Well, one of the first things is the degree of proteinuria, because again, if we have proteinuria, that suggests to us that there is some malfunction in the podocyte's ability to maintain a proper slit diaphragm. So a lot of our studies look at proteinuria reduction. However, there are some difficulties in interpreting that data because if there is significant glomerular sclerosis, you will have chronic proteinuria. So we may not ever be able to improve someone's proteinuria to 0, but we may only be able to prevent it from getting worse. Microscopic hematuria can be tricky because anywhere that there is bleeding from the glomerulus to the tip of the urethra, we can have microscopic hematuria. But dysmorphic red blood cells, acanthocytes, and red blood cell casts tip us off to that. Here is from a renal biopsy catching a erythrocyte getting extravasated through a damaged endothelium. As it goes through that process, the membrane is damaged, causing our acanthocyte or Mickey Mouse cells. And then here again, we have a cast with cells that have no nuclei. So the only anucleated cells in our body are red blood cells. That has to be a red blood cell cast. So now that we've kind of reviewed gotten our bearings within the glomerulus, let's talk about some of the new things that we have learned. So one of the very exciting areas in our field are these new antigens in membranous nephropathy, because they are really helping us understand this disease better, and also having a subtype, a diagnosis of membranous nephropathy, something a pathologist says the GBM on this biopsy looks membranous, to actually diagnoses that speak to the pathophysiology. So any disease, as we know, that's called idiopathic means that we don't understand what's happening. Primary or idiopathic membranous nephropathy is a disease that can range from non-nephrotic proteinuria to full-blown nephrotic syndrome, and it is characterized by subepithelial immune complex deposition, immune complex depositions underneath the podocytes, interfering with its ability to filter, leading to spilling of protein into the urine. And these antibodies, and this can be due to autoantibodies directed against a podocyte antigen. Can also have secondary membranous nephropathy in things like lupus nephritis as well. And it can also be paraneoplastic. So for years, we knew that there are immune complexes that were deposited in membranous nephropathy, but we didn't know why. When we look at it under the biopsy, as a biopsy, we see that when we stain for the glomerular basement membrane, there's a lot of spikes and holes. It has this moth-eaten appearance. That is because in these areas that there is not a homogeneous uptake of stain, that's because there are immune complexes deposited within the GBM that prevent the uptake of that stain. That has a granular appearance and immunofluorescence. And again, we have these electron-dense immune complex humps underneath the podocytes on electron microscopy. In 2009, there was a watershed moment where they identified in 70% of patients with membranous nephropathy had circulating antibodies to phospholipase A2 receptor. That is an antigen on podocytes. So that said that changes from being a pathologic description to pathophysiologic description. In 70% of our patients, we can identify this. Now we are able to follow the titers of these antibodies to assess our response and treatment, because as we said before, proteinuria reduction is not the end-all be-all of treating glomerular disease. And also in the proper patient population, it may allow us to negate having somebody undergo a renal biopsy. How does this work? There's PLA2R on the podocyte surface. We have an autoantibody that binds to it, creating these immune complexes that activates complement and profibrotic pathways, leading to the laying down of laminin and collagen 4, thickening that glomerular basement membrane, interfering with that proper podocyte interface. So 70% of folks have, with primary membranous nephropathy, are able to identify PLA2R. circulating PLA2R antibodies. Now, due to newer techniques using laser microdissection of glomeruli to actually pick out these immune complexes and mass spectroscopy, we have a whole list of potential antigens. And why is this important outside of this being alphabet soup and interesting trivia at a cocktail party if you are a nephrologist? There are some actual practical things from this data. So 2 to 3% of patients have this, we can identify the thrombospondin 7A. Why is that important? Because that is strongly correlated as a paraneoplastic membranous nephropathy, meaning these patients need age-appropriate cancer screening. FAT1 membranous nephropathy is associated with hematopoietic stem cell transplants. SEMA3B is found only in young patients. That has a lot of implications in the pediatric literature because they tend to not biopsy children as often as we biopsy adults. A lot of those patients get categorized as having steroid-resistant or steroid-responsive nephrotic syndrome. And perhaps this would allow reclassification of the steroid-resistant nephrotic syndrome because steroids themselves are not enough to treat membranous nephropathy. NEL1 is associated with malignancy, but also lipoic acid supplementation. And very interestingly, exotosin 1 and 2 are strongly associated with membranous nephropathy in the setting of autoimmune disease, which we used to call secondary membranous nephropathy. Most of the times it's found in lupus nephritis, and patients with positivity to exotosin 1 and 2 have more favorable outcomes. Clinically, we can only test for PLA2R and thrombospondin, but that is changing. And you could see in the future, this may allow us to risk stratify these patients as you get more data on the performance characteristics, may even allow us to forego renal biopsies in the right patient population. So based on this understanding of the disease, we can design therapeutics. We can use anti-B cell directed therapies. We can use T cell directed therapies with cyclosporin, calcineurin inhibitors. And although none are approved yet, we have a lot of therapy looking at inhibiting complement. A lot of clinical trials are looking at complement inhibitors in this disease. Now to talk about a very different disease, APOL1 mediated kidney disease, which is something that we are learning a lot of. I should also mention that most of the topics that I'm talking about today are very, very new. A lot of the, I don't have many gray hairs, so I didn't finish my nephrology fellowship all that long ago. But most of the data that we are talking about, both on the slides I just showed you and going forward, were all discovered and kind of described since I've either started my fellowship or graduated. So APOL1 mediated kidney disease is something that was found in individuals of African descent that explains the high rates of kidney disease after traditional either socioeconomic factors, other comorbidities are accounted for. Before we talk about APOL1 mediated kidney disease, we have to understand what a risk allele is. A risk allele in itself is not pathogenic. It only increases the risk, its presence only increases the risk of developing a certain disease. And it usually requires either a clinical or environmental second hit. So just because you have a risk allele doesn't guarantee that you'll develop that disease. What's interesting, however, is APOL1 mediated kidney disease only requires one set of risk alleles. Usually these risk alleles are polygenic, and you need to have an accumulation of many risk alleles to have a true clinical increased risk. So what is APOL1 in health? Its protein is part of the trypanosome lytic factor protein that helps give humans resistance to many types of the parasites trypanosomes. Those are the parasites associated with African sleeping sickness. There are a few trypanosomes that do infect humans, and the development over the last 10,000 years of G1 and G2 alleles helped confer resistance to this disease, similar to the way that the development of sickle cell trait confers resistance to malaria. So just the terminology, G0 denotes the wild type, and then there are two risk alleles denoted as G1 or G2. 35% of Black Americans will have one risk allele. So as we start doing more genetic testing, which is its own talk, we will find this. 14% of Black Americans have two risk alleles. You need two risk alleles to have an increased risk of developing kidney disease. That can either be homozygous for G1 or G2, or what we call compound heterozygous. We have one G1 allele and one G2 allele. And because of the slave trade, these these risk alleles have a global distribution, but not only in the United States of America, but also in the Caribbean, Mesoamerica, and parts of South America. And as you can see, based on what part of the world, the prevalence of these risk alleles changes. What are those clinical second hits? Well, a lot of things. Lupus folks who have high risk APOL1 genotype are at a higher risk of having progression of their CKD in the setting of lupus nephritis, hypertension, FSGS. When we think back to the days of the HIV epidemic, HIV-associated nephropathy, which was characterized as a collapsing FSGS. When we look back at those patients, a lot of them had high-risk APOL1 genotypes. And also, if we think back to the early days of the COVID-19 pandemic, if you might reach back to your memory banks, you probably had some patients that had rapid reduction in their renal function with heavy proteinuria, well out of proportion to their regular hemodynamic insults from their SIRS reaction. When we biopsied those patients, we found that a lot of them had collapsing FSGS, very similar to HIVAN. Those were called COVAN, and then looking back at that, all of these patients in our case series had high-risk APOL1 genotypes. What is the mechanism here? Well, remember, under normal circumstances, APOL1 is used to confer resistance to trypanosome, a parasitic infection. In states of high interferon, either from infections from parasites or also HIV, SARS-CoV-2, or lupus, that causes the transcription of APOL1 that inserts ion pores within the cell membrane, leading to osmotic injury and cell lysis. So you can imagine, although that is supposed to occur within trypanosomes, if that happens in other parts of our body, that can cause to the pathogenesis of this disease, especially if that were to happen in podocytes. Now, why is that important? Although there are no approved therapies for this disease, right now, doing APOL1 testing can help us explain why someone may have such severe kidney disease out of proportion to their clinical presentation. However, there are medications in the pipeline, specifically inaxaplin, that block this pore. And this is a phase 2b study that looked at giving 13 patients with high-risk APOL1 genotypes and proteinuria this medication. And on the y-axis, we see change in urinary protein to creatinine ratio. And in all of the patients except one, there's a pretty good reduction in proteinuria. So this is very promising. In this patient, this patient did not actually end up taking the medication here. So though we do not have therapy right now, there is we do have targets that are in the pipeline going forward. Now moving to other glomerular diseases and the ones that have therapy. So the first thing is I don't have to tell anyone in an internal medicine audience the importance of SGLT2 inhibitors. I think we all have started to drink that Kool-Aid. We know in the renal world that the use of SGLT2 inhibitors, dapagliflozin, canagliflozin, empagliflozin, tend to have a 30% reduction in the progression of proteinuric kidney disease to needing dialysis, which is fantastic. That data initially came from the patients with diabetes, but it's starting to hint that they are also beneficial for all sorts of proteinuric kidney disease. Why is that? Well, reduction in the filtration pressure within the glomerulus is important for slowing the progression of CKD of all causes. Why is that? In normal circumstances, tubular glomerular feedback, basically the kidney's ability to sense tubular flow throughout the nephron, helps us regulate the filtration pressure and our GFR. If we have a lot of flow, if we do not sense a lot of flow through the nephron, that causes a release of renin from the juxtaglomerular apparatus and activation of RAS. That causes preferential constriction, vasoconstriction of the efferent arteriole by angiotensin II, increasing the glomerular capillary pressure, increasing GFR. Now that is good for the short term, but the increased filtration pressure will over time can push our podocytes off of our glomerular basement membrane and also worsen proteinuria. So using ACE inhibitors and angiotensin receptor blockers, we allow vasodilation, or we unconstrict the efferent arteriole, leading there to be a reduction in the glomerular filtration pressure. That also causes a reduction in GFR, and we find up to a 30% increase in the creatinine. But that is a hemodynamic effect. That isn't true kidney damage. Why am I spending time here? Because you may see a lot of our patients that get admitted to the hospital with proteinuria kidney disease who have well-controlled hypertension, who are on high doses of losartan. Why is that? Because if they can tolerate it, the maximally tolerated dose of RAS inhibition shows better preservation of kidney function over time. I think in the cardiology world, we don't blink twice at GDMT. People are on drugs like Entresto and spironolactone for GDMT for heart failure, even though they're presyncopal. Well, we like to titrate our patients just below presyncope to help slow the progression of this disease. SGLT2 inhibitors, by inhibiting the reabsorption of glucose, increase tubular flow, leading to theoretically reduction in RAS activation and reducing the interglomerular pressure, one of the many ways we think these drugs help the kidney. So what am I getting at? Early proteinuria reduction is important. We can't do a study over the course of 10 years to see how it affects somebody's progression to ESRD. So the best proxies that we use to get a study done in 1 to 2 years are proteinuria reduction. You know, on the y-axis are different metrics of renal survival, looking at GFR preservation, proteinuria reduction, et cetera. But in patients who have proteinuria reduction, these upper lines here, this is in FSGS, this is in lupus nephritis, have better preservation of their renal function over time. So getting that early proteinuria reduction in the beginning of your diagnosis and treatment is really important for the renal survival. That data is also found with SGLT2 inhibitors. In the DAPA-CKD trial, there was a subset of patients with IgA nephropathy that also showed significant benefit. Now, this is backward, this is cumulative incidence of a renal endpoint, so the things we were talking about, and you can see that was significantly lower in patients with dapagliflozin. They also did a secondary analysis looking at patients with FSGS, and as you can see here, there is a trend towards benefit. However, FSGS is an umbrella term. It is a pathologic diagnosis based on how the kidney looks under the microscope. There are many, many, many types of FSGS. So because of that, you could imagine that different types of FSGS may be responsive, while others may not be responsive. This is a very interesting paper. It's a retrospective analysis looking at patients with other types of proteinuria kidney disease who were prescribed SGLT2 inhibitors, looking at preservation of their GFR in red and proteinuria reduction in green. Now, these diseases are rare, so there aren't a lot of patients in each subgroup, which is evidenced by the wide confidence intervals. But I think a clear trend within these diseases is noted. So moving on to IgA nephropathy. IgA nephropathy is the most common glomerular disease in the world. It's caused by plasma cells within the Peyer's patches of the terminal ileum that produce galactose-deficient IgA. This galactose-deficient region serves as an epitope for autoreactive antibodies, creating a circulating antibody-antibody immune complex that gets deposited within the kidney, recruits immune cells, and leads to the glomerular disease. This disease has gone back and forth on, a lot of things have gone in and out of vogue in how to treat IgA nephropathy. Because of the production of galactose-deficient IgA, we used to think severe or aggressive immunosuppression, meaning steroids, was beneficial. But as we all know in this room, steroids come with a lot of side effects. This trial, Stop IgA, was one of the first that moved us away from heavy use of immunosuppression. And any future IgA trial will really have to meet these criteria first. What do I mean by that? In Stop IgA, that was going to be immunosuppression versus supportive care. But it had a 6-month run-in period to maximize RAS blockade, get you on the highest dose of an ACE or an ARB just until you pass, right below you passing out, and getting your blood pressure under 125/75. Because of this intensive run-in period, 30% of the patients no longer qualified for the trial because they were able to reduce their proteinuria to that lower risk category. So again, any trial this taught us a lot, that we could probably spare a lot of our patients with IgA nephropathy from immunosuppression if we just really hit them with RAS blockade. Again, when we take that data on top of the data from DAPA-CKD showing benefit with SGLT2 inhibitors, we felt rather confident that we would only hold immunosuppression for those who are at high risk of disease, rapid renal function decline, high levels of proteinuria, despite a 6-month trial. However, a recent study from the UK looking at a registry of over 2,000 patients with IgA nephropathy shed some light onto this. Our low-risk patients, which are here in blue and magenta, have a UPCR, a urine protein to creatinine ratio, less than 0.4, which most of us wouldn't blink an eye at. 30% of those over the course of 10 years developed ESRD. People that we would say in our clinic, if I saw them, your risk of developing ESRD is low. Sure, it's lower than the other patients, but this is those are still patients that we could do something for. So based on the pathogenesis of this disease, plasma cells creating these galactose-deficient IgAs and their deposition within the glomerulus activating things like RAS and endothelium, 2 medications have been approved over the last few years, targeted release budesonide and sparsentan. In addition, in the background, factors that promote B-cell survival and complement activation are also in the pipeline for clinical trials and are very promising for treating this disease. So the first drug is targeted release budesonide. The targeted release part means that this budesonide steroid is formulated in a way that it is not released until it gets to the terminal ileum where those Peyer's patches are. So the drug company will tell you that it is a targeted release of budesonide, of steroids, to the area where the disease pathogenesis begins. Budesonide is then taken up into the hepatic circulation and metabolized and inactivated in first-pass hepatic metabolism, theoretically reducing the systemic side effects of taking a steroid. Again, these patients still were in the high-risk category with proteinuria despite optimal supportive care per that last trial, Stop IgA, and it looked at budesonide versus placebo. That showed a significant reduction in UACR, urine albumin to creatinine ratio, over the course of 9 months, and it showed relative stability and preservation of GFR during that time. Sparsentan is a dual endothelium and angiotensin receptor antagonist. Both of those pathways are upregulated in IgA nephropathy and other glomerular diseases. Things that they don't, when we think about the RAS system in medical school, we think of it as a way to defend our blood pressure in the setting of stress. But many people fail to tell you that angiotensin receptors and aldosterone receptors, also their activation also leads down to profibrotic pathways. So their blockage, interfering with that pathway, is also important in renal protection. It's not just a blood pressure lowering effect. Again, looking at patients who are high risk with significant amount of proteinuria, despite supportive care, they looked at sparsentan versus irbesartan. So the addition of endothelium blockade on top of already angiotensin blockade. As you can also see, there was a quick reduction in red in proteinuria that was sustained. The initial trial was over 9 months. That led to the accelerated approval of sparsentan, and that was also maintained through a 106-week follow-up. Interestingly, after 106 weeks, the drug was discontinued, and the difference was still seen there. It was durable at 110 weeks out. We also see something very similar with GFR. Again, we have this initial reduction due to the reduced glomerular filtration pressure. That also was sustained at 114 weeks out. What was not significant was one of their primary endpoints, looking at a composite kidney failure endpoint that took GFR reduction, development of ESRD, or all-cause mortality. So these medications now allow us to have a more tailored approach to treating IgA nephropathy based on the patient in front of us. If people outside of maximizing RAS blockade and the addition of SGLT2 inhibitors. If they have a lot of proteinuria, which could tell us that there's a lot of scarring or hyperfiltration injury, the addition of sparsentan may be beneficial. If they still have ongoing microscopic hematuria, that could tell that there's ongoing nephritis, and the use of steroids, either oral glucocorticoids or targeted release budesonide, may be beneficial. We don't have trials looking at using both of them together, although since only one of them is an immunosuppressant, I don't see why one would exclude the other. Having said that, these drugs are incredibly expensive per month. And while the pharmaceutical companies have payment plans, I think that's something that we have to think about, obviously, when treating this disease. Moving on to lupus nephritis. This in itself could be an hour-long talk that would go over by at least 2 hours. But what is lupus nephritis? That is the deposition of circulating immune complexes within the glomerulus. Where they deposit and the immune reaction to that denotes how it is graded as class 1 to 2, which is just deposition within the mesangium without proliferative or inflammatory lesions. 3-4 has proliferative and inflammatory lesions, and class 5 is deposition within the GBM and is a type of secondary membranous nephropathy. What happens in lupus? Due to malfunction in autophagy and apoptosis, as cells die, their intracellular nuclear antigens get exposed, and they are recognized by our innate immune system, toll-like receptors, damage-associated molecular proteins, et cetera, as viral components, leading to a high interferon state, leading to activation of the immune system, the production of plasma cells that make autoantigen-specific antibodies, and then T cells that are targeted against those autoantigens. For the rheumatologists in the room, I hope I didn't oversimplify that disease. The history of lupus nephritis can be very complicated. It started off with the best wedge in medicine that we know in treating any disease, steroids, a very primitive tool. And then over the preceding decades, the addition of cyclophosphamide or Cytoxan, then comparing that to MMF, then we flirt with rituximab like anybody who deals with any immunologic disease flirts with it. And then the addition of calcineurin inhibitors over the last 20 years has also been very promising. The two drugs I want to talk to are drugs that have been approved since I finished my nephrology training, voclosporin and belimumab. So as we talked about here, we have more downstream of this disease. We are targeting either T cells with our cyclosporin, with our calcineurin inhibitors, or plasma cells. One of the many important cytokines that leads to plasma cell survival is BAFF, B cell activating factor. I don't know where the second F comes from. So the first trial is a drug, belimumab, which is a monoclonal antibody against BAFF. It was used in the treatment of what we call extrarenal lupus, or SLE, for everyone that's not a nephrologist, for a while with good results. And there was this observation that there were reduced renal flares in those patients. Keeping in mind, 30% of patients with SLE will also have renal flares. So they added on belimumab as on top of standard induction therapy. This trial was a little odd in that they had an interesting composite endpoint that wasn't used in many trials, so it's hard to compare apples to apples, but it looks at preservation of GFR, proteinuria reduction, or need to use rescue therapy for flares, which is a fairly clinically important endpoint. And as you can see here, it showed benefit. Voclosporin is also an interesting drug. It's what we call a next generation calcineurin inhibitor. It's 4 times more potent than cyclosporin, and due to the fast elimination of its metabolites, it doesn't require any drug level monitoring, which can be very difficult and time consuming for patients taking either tacrolimus or cyclosporin. Similar design, looking at adding this onto standard induction therapy of MMF and steroids with a more traditional primary outcome of complete renal response, looking at reduction in proteinuria less than 0.5, and the rest you can see here. And as you can see, both in this here being complete renal response or partial renal response, voclosporin in blue had a statistically significant benefit. However, what's very interesting is this benefit, this meaning a CRR, was driven primarily by proteinuria reduction. Why is that important? Well, if I asked some of the residents here, how do calcineurin inhibitors work? You would say something to do with T cells. And while that's true, calcineurin inhibitors inhibit calcineurin, which interferes with the ability to transcribe NFAT, which leads to T cell proliferation. There are also non-immune effects of this drug. Calcineurin also is involved in the breakdown of synaptopodin, which is integral in the maintenance of the actin cytoskeleton of the podocytes. So the question is, do CNIs in lupus nephritis work via immune mechanisms or non-immune mechanisms? We can see here, again in blue, that there is a rather rapid reduction in proteinuria, which is an important clinical outcome in treating any glomerular disease. So does it matter? I don't know. The thing is, though, if we are only treating at the cytoskeleton, if it's not working through immunologic means, then this is a very distal therapy in the pathophysiology of this disease. And one would expect that if we take people off of voclosporin, that their proteinuria would return. So as far as its ability to induce remission from an immunologic standpoint, I don't think we entirely know. It is a CNI, and as we know, CNIs can cause CKD. And what we can see is in a longer-term follow-up, looking at 36 months compared to the initial 9 months, the reduction in proteinuria was sustained. However, after the medication was stopped, we can see that these confidence intervals start to cross. But also importantly, the GFRs remain stable. It doesn't seem to chew up the GFR like tacrolimus or cyclosporin does in, say, our transplant patients. These medications were added into the KDIGO guidelines for treating lupus nephritis this year. And as they're usually used as add-on therapies, not in isolation. When to use one or the other, or how we use them together, is not known. One thing we have to, as my associate program director told me when I was a fellow, is that immunosuppression is great for patients with lupus nephritis, but at some point you'll have to put them in a bubble, meaning we have to be worried about the side effects of over-immunosuppression. So how to use these medications in combination is not quite found out yet. And because they are made by different drug companies, I don't know if we'll ever have a head-to-head trial. So when do I reach for one over the other? I reach for voclosporin in folks who have pretty good preservation of their GFR and who have more of a proteinuric lesion, meaning they have higher degrees of proteinuria in their urine compared to, say, nephritis. Belimumab is great if they have a lot of extrarenal symptoms, because voclosporin is only approved for lupus nephritis, or if they were to have a high cellular infiltrate, a lot of inflammation on their biopsy. There's no data to back that up, but just based on how we think about the pathophysiology, that makes sense. Having said that, I think anyone in this room in the age of evidence-based medicine knows that that's not always the best reasoning for choosing one therapy over the other. But right now we have no data, so that's the best that we can go with. Briefly at the end, we want to talk about, we have abilities now to reduce the steroids used in ANCA vasculitis. So to review, ANCA vasculitis is a little different than the other glomerular diseases that we talked about. We have neutrophils that get primed by some immunologic insult, traditionally thought to be a viral infection or some acute illness. That leads to the migration of anti-nuclear antigens to the cell surface that are recognized by circulating anti-nuclear antibodies. That leads to the activation of these neutrophils and invasion of the vascular compartment. What's interesting is cleavage products of the complement system can also prime and activate these neutrophils as well, specifically a cleavage product called C5a. Patients that have evidence of complement activation on their biopsy with ANCA vasculitis tend to do worse. And in mice that had C5a receptor knockouts seem to be rescued from ANCA vasculitis as well. So that's the theory as to why this medication was developed. To review complement briefly, we have 3 different pathways that converge to create a membrane attack complex, which gets inserted into our invading cell's membrane, leading to cell lysis. that's how we typically think of it. But these cleavage products, right? C3 gets to C3A to C3B, C5 to 5A, 5B, et cetera, we only think really of the ones that either lead to cleaving more complement or the creation of this membrane attack complex. We don't really spend a lot of time in medical school thinking of the other cleavage products. C3A and C5A, which we used to forget about, also attract the immune system. Our neutrophils have C5A receptors that can also lead to their priming, release of reactive oxygen species, and amplify the immune response, which is good in the case of an infection, which is bad when they are targeted against your endothelium. So along comes this drug called avacopan. Avacopan is a pill. It is not an infusion. That is an antagonist against C5A, the C5A receptor. This trial was designed to use, so traditionally, ANCA vasculitis is treated with a lot of steroids and then either cyclophosphamide or rituximab. As anyone, again, knows in this room, high doses of steroids for prolonged periods of time are bad. So this drug here wanted to see was avacopan on top of traditional induction therapy versus traditional induction therapy versus placebo, versus prednisone. And that the duration of this trial was over 52 weeks. I mumbled that a little bit. This trial was designed to see if avacopan can replace steroids in treating ANCA vasculitis. Okay, a lot of our patients with ANCA vasculitis die because of our treatment, slightly longer than they would have died from the disease. Although with rituximab and cyclophosphamide, that's changing. They're doing much better. But that's the traditional way in which these patients were harmed. It showed that avacopan reduced the risk of relapse and also reduced the risk of toxicity from glucocorticoids, which is fantastic. It also seemed to improve GFR. However, it was not truly steroid sparing, but it was steroid reducing. Some of these patients came into the trial on weaning doses of prednisone. But as you can see here, there's still a lot less prednisone used in the avacopan group in red compared to the control group. And any drug in my mind that can reduce prednisone use is a clinically significant intervention. The only caveat to this is of all the trials that looked at avacopan in ANCA vasculitis, there's only 287 patients that ever received it in a clinical trial setting. So the long-term effects of this, the side effect profiles, still may not have revealed themselves to us. However, like I said, any drug that can allow, with a good side effect profile, that can allow us to use less steroids is very beneficial. The complement pathway is a very promising target for treating glomerular disease because, again, in any disease where there is immune complex deposition, although there is none in ANCA, that activates complement, which helps recruit the immune system. So as you can see here, all of these medications are under investigation for diseases like membranous nephropathy, ANCA vasculitis, IgA nephropathy, lupus nephritis, et cetera. So to conclude, early proteinuria reduction is important. Many of our patients will have APOL1 risk alleles, though the therapeutic implications of that at this time are still to be determined. We maximize the use of RAS inhibitors and SGLT2 inhibitors when we're able to get that to help reduce proteinuria early. B cells are heavily involved in the pathogenesis of our glomerular diseases, and complement serves as a promising new target in immune-mediated kidney disease. Hopefully, as we further elucidate these immunologic pathways within glomerular disease, we can move from the blunt sword of steroids to more targeted and less toxic therapies going forward. And that's all I have. Thank you very much.